Okay, Anna, it's 3 o'clock if you'd like to start.
All righty. Well, good afternoon, everyone, and welcome to the 5th webinar in our series on health literacy and chronic disease. My name is Anna Shao, and I am the program coordinator at the Horowitz Center for Health Literacy. Housekeeping notes. If you haven't already, please complete our pre-webinar survey at the link here. After the webinar, you can request the slides at this link here, as well as the link that Catherine posted in the chat. As an attendee, you are automatically on mute, just to minimize distractions. If you have any questions, please type them in the Q&A box, and when I take my breaks, I will ask my colleagues, Catherine and Debbie, to relay those to me. And finally, if you're having trouble with the audio, you can call into the webinar at this phone number here with the access code. So this webinar is one of 6 created by the Horowitz Center for Health Literacy at the University of Maryland School of Public Health, and we did this in partnership with the Maryland Department of Health. The purpose of these webinars is to provide health literacy technical assistance to health departments and local health improvement coalitions in their chronic disease prevention and management work. We created these web trainings for people in county health departments and in LHICs. And to take our other trainings, visit the link in this slide. Today, our focus is on creating more engagement with diabetes programs, specifically within the programs themselves. Along the way, I'll share some tips from a health literacy perspective that can help keep your participants engaged throughout the program. So let's first start with why we care about engagement. First, if we have participants and patients who actively participate in our diabetes programs, that can lead to improved health outcomes. And if we want widespread and measurable improvements, we have to work with folks who are a little less motivated or less willing to engage in our programs. The very motivated, very engaged folks, while they're easy to find and easy to teach, they're a small group, and when you think about all of the at-risk people in our communities. And a crucial part of achieving the goals in the Maryland Diabetes Action Plan, especially for preventing diabetes, involves people signing up for, staying in, and completing lifestyle change programs. So by the end of this webinar, our hope is that you should be able to describe why it's difficult for people with low literacy skills to understand and process health information, and list 3 methods for helping patients understand diabetes concepts and management skills. So to get there, those objectives, first we'll put ourselves in the shoes of someone with low literacy and see why reading can be so difficult. And then we'll talk about some actions you can take to help patients and participants understand diabetes information and adopt those management skills. And finally, I'll share some resources. So first, we'll walk a mile in their shoes, as they say. We'll understand populations with low literacy. So I want to start by pointing out that education level doesn't say as much as we wish it did. People usually read 2 to 4 grade levels below their highest level of education. So even if the registration form or patient form says that my participant or patient finished high school, I shouldn't assume that they can read at a 12th grade level. To dive a little deeper here, I want to break down the process of reading and how that leads to comprehension. Reading involves recognizing letters and words. So imagine if you couldn't read a language for whatever reason, like the symbols below. If I gave you a key that matched every symbol to each letter of the English alphabet, you have to go symbol by symbol to read this message. You'd have to create words from each symbol and then figure out what this sentence actually means. And that's similar to how folks with low literacy skills read, letter by letter, word by word. But the exception here is that you have the advantage of recognizing words, and you can predict what the string of symbols might say before you even finish reading it. And so this text here, the Wingdings text reads, "Reading is a complicated process." So after reading comes comprehension. That means that you're creating meaning from the letters and the words that you're stringing together. So words become sentences, which when you string them together, create that meaning. And when you're not a strong reader, you can get tripped up along this process and things are harder to understand. So if your vocabulary isn't so extensive, or if you read slowly, that all creates a barrier to making meaning. So some examples that give you a taste of what it means to slow down your reading and comprehension. The first example here is, imagine if you had to stop after every word to understand a sentence. That slows you down in your reading and your comprehension. The next example, imagine having to read from right to left and backwards. Again, that slows you down too. So here that says, or having to read a sentence backwards and from right to left. So I had to slow down quite a bit to read that and understand that. Another example here, imagine having no prior experience using context clues and inferring the meaning of an unfamiliar sherblue. So sherblue is a word that I just made up to put in there, but not knowing it can slow down your comprehension. But for you and for more advanced readers, your context clues and previous experience helped you predict that new vocab word, or that gibberish in this case, means word here. So that's a taste of what it means for having low literacy skills and having your cognitive processing slow down until your brain adapted. So for us, though, we were able to adapt quickly, and you could quickly make some meaning out of the way I jumbled things up. But cognitive processing, this ability to use that reading and the language and comprehension to create a complete picture of a concept, that's much more difficult for folks with low literacy. So much like this picture on the slide here, the words and sentences come together like a puzzle to create understanding, and that's how cognitive processing works. So imagine not being able to adapt, though, in those previous examples. Here's what might happen if you have lower literacy skills. It means that the cognitive processing process is difficult for you. And for whatever reason, maybe you don't start from the same spot that language that you're reading does. In some languages, we start at the top left and go right, left to right, and then top to bottom. In other languages, we start from the top right and go from right to left and top to bottom. Or maybe it's hard to recognize new things that represent other meanings. For example, a sign or a symbol or an abbreviation or even a synonym. You may know what the meaning behind the sign or behind the symbol is, or behind the abbreviation, but once you put that place marker there, it makes it difficult for you to process what that means. And if you have low literacy skills, your cognitive processing is difficult because you may not be able to follow the conversation with your provider or a diabetes educator, and that makes it hard for you to understand the conversation or draw inferences from that conversation. So what happens as a result of that? As a result, a person who has low literacy skills may not ask questions when they don't understand. Maybe they answer yes to your questions when you ask them, did you understand? And even when they don't. That might be because they're too embarrassed to admit that they don't understand, or for whatever other reason. And for that reason, we do encourage folks not to ask that yes or no question of did you understand what I said. We encourage the teach back method, which we'll go into later on in this presentation. And people with low literacy skills may not read much or at all, so their experience is mainly limited to what they've personally had themselves or heard from other people, and thus their information base is a little bit smaller than what we might expect. All of this is to say the most important thing for us to do as diabetes educators and as public health professionals, as program planners, program implementers, is to make it easy for your patients and participants to understand the information you're giving them. At the Horowitz Center, we promote what's called a universal precautions approach, where you automatically treat everyone the same, no matter their literacy skills. And even people with high and strong reading skills appreciate easy to understand information. I know that's the case for me. So I want to take a break and pause here and check in with Catherine and Debbie and to see if there are any questions.
Yeah, there's no questions at this time, Anna.
All right, folks. I encourage you to ask them as they come up. So let's talk through how we might recognize someone with low literacy. A patient or a participant might say that they forgot their glasses and ask you to read the information to them. Maybe they'll ask you to take whether it's okay to take the information home and discuss it with their family members. Or during the interaction, they might ask few or no questions. In terms of medicine, the way that people take their medicine or the way that they talk about their medicine might also show some signs of their literacy. So you can maybe tell from the fact that they identify pills just by looking at them and their shape and color rather than reading the label. Maybe they have trouble taking their medications correctly. So whether that's the amount they're supposed to take, what time they're supposed to take it, whether it's supposed to be on an empty or a full stomach, things like that. Or they have trouble telling you the names of their medicines, telling you why they take it, or how much that they're supposed to take. In terms of interacting with the healthcare system, folks with low literacy may not be able to finish their registration forms. Maybe they can't give you a complete medical history, so they can't describe some of the conditions that exist in their families. Or maybe they don't follow through on tests or referrals, specialists, or for other diagnostic procedures. They might also frequently miss appointments. And though I do want to point out there may be plenty of other factors at play for these specific indicators in the healthcare and medicine areas, but it's still important to consider that they might be exacerbated by low literacy. I completely understand and acknowledge that there might be some other social determinants at play, but I do not want to undermine literacy is one of them. So we've talked about understanding populations with low literacy. Now let's move on to helping your patients and participants understand diabetes information and adopting those skills. So just to take a pause and a breather here, the tips that we're going to share with you about how to address low literacy and create some engagement, they might sound intuitive and simple. However, it might take some unlearning of current habits before you get the hang of some of these health literacy techniques. I want to encourage you to go easy on yourself and remember that these changes won't happen overnight. It will take some reflection, self-awareness, and practice, lots of practice before you get the hang of it. But your patients and your participants will be better off for it. Just to give an example, we have a colleague who's pretty well known in the health literacy field and just starred in a documentary on diabetes. And even though we know that he knows these health literacy techniques, we heard him go against some of these tips just in normal conversation. So don't be hard on yourself and recognize that this is a process, even for the so-called experts. So how can we best help our patients understand and engage? The first technique I want to call to attention is creating opportunities for your patients and participants. Let them actively participate during conversations and skill building activities in your sessions and workshops, and let them demonstrate the action that you want them to perform. I will go into a little more detail about this in the next slide. If you're in a group setting, it's also a great idea to let the group members learn from each other. It's a really valuable resource to have peers in the room. So for example, the group can share tips for how they've been eating healthy, how they've been staying active, or even give tips for what grocery stores have good deals and good sales on healthy foods. And finally, creating that environment where it's a safe place to learn new things is really important. So let your patients and participants know that they're not failing, but that each mistake or each stumbling block is an opportunity to learn and improve. After all, diabetes management and prevention is very complicated. So we want to make sure that there are plenty of opportunities to practice, to stumble, and to get back up and try again. So I mentioned demonstrating the action. If the goal is for the patient or participant to adopt a specific behavior, it's important for you to show them how to do it. If you have visual aids like posters or charts or pictures, or even a sample machine, make sure that you use them during the demo. And we're really fond of this model. I do, we do, and you do. So first you demonstrate the action, and then you do the action together with the educator, with the patient, or the educator with the participant. And then finally, you give time for the patient to do it by themselves, whether that's individually or in a small group, just them together. And that way, they've been exposed to the action 3 times. 2 times they saw it demonstrated, and then the other 2 times they were able to do it actively participating themselves. So you can show people, your participants, how to check their blood sugar, and then have them demonstrate how to do that. You can do it together, and then you can have them demonstrate how they would do it by themselves. The next technique I want to highlight is catering to your patient's context. And so I've broken this down into 3 sub areas. So first is talking about information in a real world context. So for example, if you're telling your participant or your patient to eat fewer processed foods and more fresh fruits and veggies, you can build on that context and put it in a real world context for them and say, when you go to the grocery store, it's best if you shop along the outside of the grocery store and avoid the middle aisles. And it's important to be open and probe about phrases like processed foods or fresh fruits and veggies in case that they're confusing for your participant. You can further explain that processed foods usually come in bags or boxes and have really long ingredient lists with names that are hard to pronounce. And you can explain that fresh fruits and veggies means that they are raw and uncooked and don't come dried or in a jar or in a can. Next, to cater to your patient's context, find out what your patient already knows about diabetes or about preventing diabetes. So for example, maybe the patient knows diabetes has to do with sugar, and you can build on this and explain that diabetes means there's too much sugar in your blood. And then you can go on and explain, how do we keep you healthy in light of that? And finally, when it comes to catering to your patient's context, it's really important to find out what motivates the patient. So for example, if the motivation for your patient or your participant is, I want to see my grandchildren grow up, you can build on that factor and motivate them further and build on that context and tie it to preventing or managing diabetes. So saying, I know you want to see your grandchildren grow up. So taking care of your diabetes or even preventing diabetes, we can make that happen for you. I also want to draw attention to the emotions that can come with learning new skills and new habits. It's important to be aware of those because learning new things and adopting very new lifestyles can be pretty frustrating and overwhelming, especially if it's an overhaul. So to the extent that you're able, I would encourage you to let the patient decide the pace of the information that they're receiving and not overwhelm them if you can. We also recommend the technique of chunk and check, where you teach a few new things at a time and then check for questions or understanding after that. And that reduces the information overload. If one thing on your list is new, so it says here you can teach 1 to 3 new things, but if one thing on your list is super new or very difficult, or has a lot of parts, stop at the end of that one item and check for understanding, just to make sure you're not overloading your participant or your patient. It's important to think through how much processing time your participant or your patient needs with the new information and use that to guide how you chunk the information you teach. We'll go over a technique for chunking and checking shortly, and that's teach back. So along with chunking and checking comes with this notion of breaks. It's important not to overload a patient or a participant with information, as I said earlier. So after you explain a new skill or a new concept, it's a good idea to take a break and use this time to review or to answer questions or ask questions just to make sure folks understood. Or you can use that time to practice the new skill or concept. And that gives your patient or your participant some time for the new information to sink in. And finally, for this chunk of techniques, I want to encourage you to be an active listener for your patients and participants. Give them time to talk and listen to what they're saying. Do they have any fears or concerns, and can you address them? And if you're not sure you understand what they're asking or what they're saying, it's okay to ask questions to clarify. You can say something like, I say X, Y, and Z, and I think that's what you mean. Am I on the right track? Can you help me understand? And it's important not to judge your patient, but to try and imagine what it would be like in their shoes, similar to that exercise we did in the beginning of seeing and walking a mile in the shoes of someone with low literacy skills. It might be that the person doesn't speak English as their first language, or that they have different beliefs from your own. Regardless, it's important not to judge your patient or participant. And so from there, it's good to be open to their point of view and work from there. So I just talked about creating opportunities, demonstrating the action, catering to the patient's context, being aware of emotions, giving breaks, and being an active listener. I want to check in with Catherine and Debbie. Are there any questions from our participants?
Yes, Anna, there's one question, and the question is, do you have any suggestions on the best ways for active participation in virtual classes?
That is an excellent question. I know that there's a lot of sensitivity around, especially around connectivity, and requiring folks to turn on their videos if you're in a video conferencing platform, just because I know that that takes up a lot of bandwidth, especially for folks who maybe don't have that kind of bandwidth. So that's an equity concern. I know that there are features within specific platforms that allow interactions like raising your hand or giving feedback like thumbs up or a clap. I also know that there are breakout rooms. I think that might be exclusive to Zoom. I'm not 100% sure, but I know that that's been one way to break out the larger group and create some engagement in some smaller activities that way. Those are some that come off the top of my head. Anything from you, Catherine, or from anyone else on our panel?
One that I've used in class is polling. So I can do a quick question to the group and people have like 30 seconds or a minute to respond. And then, and I don't know if that, again, if that's a Zoom only feature, but then it'll show up the percentage of the class or participants who, you know, you set up a poll with multiple choice options, and then you can kind of tell where people are. So that's another way to encourage engagement. And then I think, like Anna said, a lot depends on the platform that you're using. I know that some have whiteboards and you can share that and different people can draw and engage.
Yeah.
So that was the only question that we had.
Okay. And there's always the chat function. I know that it can be a potential place for distraction or people going down rabbit holes. But that can also be a way for you to engage, especially if folks' connections aren't as strong as we'd like. You can say, feel free to type your answer in the chat box, or maybe you can start a quick discussion in the chat box. Yeah, if you have that function, that's another way to create engagement. So that's a great question. Thank you so much. So moving on to some more techniques for creating engagement. This technique is around using plain language, using simple words to make it as easy as possible for your patients and participants to understand what you're saying. So for example, saying blood sugar instead of blood glucose, saying cavities instead of caries, or saying salt instead of sodium. We did talk quite a bit about plain language in our first webinar, and I highly recommend that you go check that out. We put out the recording and it's on that sign up page. And if you're looking for help with some plain language explanations or definitions, two really great resources are, one is from the CDC. It's called Everyday Words for Public Health Communication. They have an online index in there where you can search for words and it gives you a plain language explanation. And the second resource comes from United Health Group. They have a glossary called Just Plain Clear, where you can type in the health word and it comes back to you with a plain language explanation or definition. And they also have it translated to Spanish and Portuguese. So that's a really good resource too. I've included those at the end of the slides here. And speaking of using simple words, it's also good to use the patient's own words. That can help them feel comfortable and they can understand more, and you can connect with them on that level. So use those active listening skills. Listen for the words that they use to describe their situation. And if you're not sure what they mean, feel free to ask. I heard you say this word or this phrase. Can you explain what that means, just so that we're on the same page? And you can include the official term for a condition if you'd like. So for example, if someone calls their diabetes their sugar, you can say, I can help you learn how to take care of your sugar or your diabetes. And that way you're kind of pairing them together and helping them connect those terms together. Another technique is using different formats to present information. And that can help people digest the materials and the information that you're giving them. It also, using various formats like images, video, and text, caters to people's different learning styles. And that means that you're not relying only on written text. A lot of people are visual learners, so using pictures or charts or diagrams or even videos can really help expand understanding and create some engagement. And of course, our default of using text. It can be helpful to give handouts or to give written booklets or things like that, especially for folks to take home and reread and reference on their own later. And so along the lines of text, it's also good to give verbal instructions and repeat them, especially since many patients may have difficulty with reading. So when you speak the instructions out loud, that helps reinforce what they're supposed to do. And it's also helpful to repeat the instructions. Repetition helps patients and participants remember what they're supposed to do, and it reinforces the new information. I know that even when I was taking classes and the professor or the teacher or the educator sometimes only gave instructions one time, and then I had to turn to my classmates and say, I was listening, but I only caught half of what they said. And so I remember that some of my best teachers made sure to repeat themselves at least once or twice, not because they were worried we weren't paying attention, but just because it helps helps that information sink in better when you've said it a couple of times. And I alluded to this earlier when I was talking about chunking and checking. I highly encourage this technique called teach back. Teach back is a method for confirming understanding after you've given someone some instructions or some new information. If a client or a patient or a participant can tell you what they learned and what they're supposed to do, then you know that they understood what you told them. I do want to emphasize that teach back is not a test whatsoever. If anything, it's a test of the person who's giving the instructions, not a test of the patient. So after you explain a concept or an action, you check for understanding. So you can say something like, I want to make sure I did a good job explaining X, Y, and Z to you. Can you tell me in your own words how you'll take this medicine when you get home? And so this statement and the onus of teach back is all about the communicator, the information giver, taking responsibility for making sure they did a good job clearly explaining to the participant or the patient. So we're going to watch a video together showing a clinician or an educator teaching a patient or participant about low and high blood sugar. So as we're watching this video, take note. What do you notice? What sticks out to you?
Well, Sharon, your blood sugar results since you came home from the hospital are all within normal range that we're looking for. So congratulations on keeping on your diabetic diet. And it appears that your medication is at the right dosage currently. But sometimes when you're home from the hospital, your diet changes a bit and your activity level changes a bit. So it is important for us to continue to watch it. Okay. As you can see from this handout I have here, if you notice that your heart is going very rapidly, or if you have a lot of sweating going on, or if you feel like you're going to faint, dizziness, I want you to check your sugar. And certainly if it's under 70, or if you're feeling like you're going to faint at that moment, I don't want you to wait to take your blood sugar, but go ahead and drink some orange juice, or if you're away from home, take a little candy bar into your system so that the sugar can start bringing up your blood sugar level. Okay. Now, if your blood sugar is too high, you might notice that you're peeing a lot, or that you're drinking more than usual, or you're just excessively tired. Those are all things that we worry about with high blood sugars. This is a lot of information that I'm giving you, and it's very important that you understand the signs and symptoms to look for. So in order to be sure I was clear, can you repeat back to me the signs and symptoms you look for high blood sugar? Okay. Low blood sugar is 70. And I sweat, and I pee a lot, and then the high one is 200, and I realize that was a lot of information for us to review, so let's separate it into the symptoms for low blood sugar and treatment and the high blood sugar. All right, so for the low blood sugar, this is where your monitor is under 70. Okay, you might feel your heart racing, you might notice a lot of sweating, and at times you feel dizzy or you're going to faint. And that's when you would treat yourself with taking in some orange juice, or if you're away from home, a little candy bar, and and that will absorb some of the sugar rapidly and will bring your blood sugar up. This is very important because of the risk of you fainting. So I want you to relay back to me what you would look for symptoms and how you would treat it.
Okay, so low blood sugar is below 70, and I might be dizzy, I might sweat a lot, and my heart could race.
Correct.
And that's when I want to have orange juice, or if I don't have anything like that available, with candy bar,
Right.
so that I get sugar in my system.
Now for the high blood sugar, this is where your monitor reads over 200 on 3 occasions over a 2-week period of time.
Okay,
And those symptoms to look for would be if you're peeing a lot, if you're feeling a lot of thirst more than normal, or if you're just a lot more tired than what is normal for you.
okay,
And for that, you would watch your diet then to see if you could bring down the carbs a bit, or you could just call our office for recommendations at that point.
okay.
All right, so can you let me know what you would experience if you had any high blood sugar?
I'd be tired, I might be really thirsty, drink a lot of water, and I might have to go to the bathroom a lot.
Right.
And then I need to check and make sure that if I'm over 200 or 3 or more times, that I call the office.
Right. Now, the home health nurse is going to come and visit with you on a twice-a-week basis for the next 2 weeks.
Okay,
And you'll be showing her your little diary that you're keeping track of your sugars, and she can contact our office as well.
okay,
Okay, I've got a handout here. I want to review all the things that we talked about. So take this handout home with you, and you can look it over if you have any questions about that.
okay,
And certainly call our office at any time.
all right.
Okay.
So what kinds of things did you notice about that interaction? Just take a minute here to ruminate on what you observed and what you liked or didn't like about that interaction. For me, I noticed that the provider or the educator explained a lot of things and then asked the patient, can you relay back to me what you learned? And then in the process of the patient or participant telling them back what they heard, she realized, oh, I gave you too much information. And that's because she jumbled some of the symptoms for low and high. And so she realized, oh, she's gotten some things wrong, and it's not, oh no, they failed. It's, oh no, I didn't do a good job explaining to you because I gave you way too much information at the beginning. And so she said, okay, let's divide this into low and high, and then we'll check after each one of those. So she split up that explanation, and after each small bit of information, she checked with the patient and or the participant for understanding and said, okay, so I want to make sure you understood and that I explained clearly. Can you relay back to me? And I also noticed she said, I want to make sure that I was clear. So again, she's taking that responsibility on herself. And so just to go over one more time, the steps for teach back. You explain what the patient needs to do, ideally in a small chunk, just like what we were talking about earlier with chunking and checking, not giving people too much information in the beginning. And then from there, you ask them, can you explain in your own words what you'll do when you get home, or how you're going to explain this to a family member? I want to make sure I did a good job explaining and that I was clear. And then after the patient or participant gives you back what they learned in their own words, you can assess and see, you can see whether you need to reteach or go over the concept again, just to make sure that they understood, and have them teach it back to you. And the final technique I want to talk about is reviewing previous information. So it's really good at the beginning of a new session or a new class or a new workshop to go ahead and take about 5 or 10 minutes at the beginning to review what you talked about during the last session. So you can highlight key points or key behaviors to talk about and say, so who remembers what we talked about last time, and what were the main things that we emphasized. And this, again, helps reinforce old concepts and skills that you already went over, but maybe people need a refresher. And this is also a great indicator for you, a good way to find out whether you need to reteach some of the information that you already covered. And that's a really good technique for making sure, A, that your patients and participants understood, but also remembered what you taught them. So in this chunk, we talked about using simple words, using your patient's own words, using different formats and presenting information, giving verbal instructions and repeating those, using teach back as a method for checking understanding, and reviewing previous information at the start of a new session. So I'm going to pause here and check in with Catherine and Debbie to see if there are any questions.
No, there weren't any questions, but there have been a couple comments in the chats that I'll just let you know. Renee Wiggins brought up that the video didn't show any pictures and she was way too wordy. And then Lisa McCoy mentioned that she liked it better when she separated the teach back between the low and the high blood sugar, so she was chunking it. So those are the comments that we've had in the Q&A in the chat box.
Great, yeah, those are great observations. And I highly encourage you to adapt teach back to your own clients and patients and participants. And you know them best. So using what you think would be best for them to engage and understand, whether that's pictures, whether it's breaking it down into small bite-sized pieces. Yeah, you all know best. So great observations. So I want to wrap up and share some resources that you can use to continue in this process of engaging your participants and patients. The first two I already mentioned when we were talking about using simple words and using plain language. I also want to mention here again, our first webinar was about plain language, so I recommend that you check that out. And there are two great resources here for TeachBack. If that was your first exposure to TeachBack, there's a really great toolkit out there called Always Use TeachBack. And there's an interactive learning module. It's 45 minutes, and it's got a lot of great modules that you can interact with and do some role play for lots of TeachBack situations. You basically follow a patient from discharge from a hospital all the way to taking care of themselves at home and doing a follow-up visit, and doing that role play of how you would do teach back with them along that continuum of that journey. I also want to draw attention to our final webinar coming up next Wednesday at 3 o'clock. We'll be talking about the intersection of oral health and diabetes, and we'll be sharing what diabetes educators need to know about periodontal disease and diabetes. And so you can sign up at the link here on this page. And it's also on this page that you can access all of our previous webinars and those recordings. So before I check in one more time with my colleagues, I want to draw your attention to some final wrap-up and housekeeping items. If you can please complete our post-webinar evaluation after this, we'd really appreciate that. We encourage you to join our email list where we send out resources and upcoming events and just news about health literacy and the Horowitz Center. If you'd like to request this slide deck, you can do so at the link here. This link is also on that sign-up page that I showed in the last slide. And finally, if you have any questions or any follow-up items, we encourage you to email us at healthliteracy@umd.edu. So I'm going to do a final check-in with Catherine and Debbie and see if there are any questions or comments from our attendees?
No final comments
All
or
right.
questions.
Okay. Well, I hope this was helpful for folks. We really appreciate your time joining us, and we look forward to seeing you at next week's webinar.
Great.
Thank you.
And you've stopped the recording?
I think
Or do I do that?
you can stop it, or when you end the event, it just stops.
I just stopped it. Okay, just want to